Welcome to this Step 2 clinical knowledge review on skin and soft tissue infection test-taking strategies. This video is designed to help you recognize common question patterns and apply clinical reasoning efficiently on exam day. We are going to cover cellulitis, erysipelas, necrotizing fasciitis, diabetic foot infections, and abscess management. Remember, the goal here is not to reteach you every detail, but to help you recognize the patterns that board examiners love to test. Here is what we will cover today. First, we will learn to recognize high-yield question stems for skin and soft tissue infections on board exams. Second, we will apply test-taking strategies for distinguishing simple infections from limb-threatening and life-threatening ones. Third, we will master the next best step question format for wound and infection management. Make sure you have reviewed your first aid, your question bank, and pathoma chapters on infectious disease and dermatology. This video focuses on applying that knowledge strategically on exam day. The first strategy for skin and soft tissue infection questions is learning to distinguish simple infections from dangerous ones. When you see a question stem with well-defined borders, no systemic toxicity, intact sensation, and stable vitals, think cellulitis or a simple abscess. These patients are managed outpatient. However, when you see pain out of proportion to the exam findings, crepitus on palpation, rapidly spreading erythema, hemorrhagic bullae, hemodynamic instability, or grey discoloration of the skin, you need to think necrotizing fasciitis immediately. The board loves to test this distinction because the management is completely different. Necrotizing fasciitis requires emergent surgical debridement, not just antibiotics. Strategy 2 is learning to differentiate superficial from deep infections based on physical exam clues. For superficial infections, the board loves to describe sharply demarcated raised borders, which points to erysipelas, diffuse warmth and erythema without sharp borders, which points to cellulitis, and fluctuant swelling, which points to an abscess. When you see these findings without systemic toxicity, think outpatient management. For deep infections, the exam will describe pain out of proportion to what you see on exam, wooden hard induration, skin that has lost sensation, rapid progression despite being on antibiotics, and gas on imaging. These findings point toward necrotizing fasciitis or a deep space infection requiring urgent surgical intervention. This superficial versus deep distinction is one of the highest yield frameworks for these questions. Now let us look at 3 high-yield stem patterns you will encounter. First, the cellulitis and erysipelas stem. You will see unilateral lower extremity warmth, erythema, and swelling. For erysipelas specifically, they will describe sharply demarcated, raised borders, often on the face or legs. Always look for a portal of entry like tinea pedis or a break in the skin. Second, the necrotizing fasciitis stem. This is severe pain out of proportion to what you see on exam, rapidly spreading erythema, crepitus on palpation, hemorrhagic bullae, and a patient who looks septic. This patient is often diabetic or immunocompromised. Third, the diabetic foot infection stem. You will see a diabetic patient with a foot ulcer, loss of protective sensation on monofilament testing, foul-smelling discharge, or exposed bone when you probe the wound. When bone is palpable on probing, you must think about osteomyelitis. Here is your first practice question. A 55-year-old man with poorly controlled diabetes presents with severe left leg pain that started 12 hours ago. He is febrile, tachycardic, and hypertensive. The left leg shows tense edema, dusky discoloration, and hemorrhagic bullae. Pain is out of proportion to visible findings, and you feel crepitus on palpation. The question asks, what is the most appropriate next step? Take a moment and think about what pattern you are recognizing here before we walk through the answer. Let us walk through this answer. Step 1. Spot the pattern. You have a diabetic patient with rapid onset pain, crepitus, hemorrhagic bullae, and hemodynamic instability. This combination screams necrotizing fasciitis. Step 2. Apply the rule. Necrotizing fasciitis is a surgical emergency. The definitive treatment is always emergent surgical debridement. Antibiotics are important, but they are adjunctive, never the primary treatment. And do not waste time with imaging when the clinical picture is this clear. Step 3. Eliminate the wrong answers. Option A, antibiotics alone, is never sufficient for necrotizing fasciitis. Option B, getting a scan only delays life-saving surgery. Option D, observation, is dangerous in a septic patient? The correct answer is C, emergent surgical exploration and debridement. Remember, on boards, if a question stem gives you crepitus, pain out of proportion, and sepsis, the answer is almost always go to the operating room. Here is your second practice question. A 28-year-old otherwise healthy woman presents with a 3-centimeter painful, fluctuant erythematous mass in her axilla. She has had 2 similar episodes in the past year. She is afebrile with stable vital signs. What is the most appropriate management? Think about what the key finding is here and what the board is testing you on. Let us walk through this answer. First, read the question carefully. The key finding here is fluctuance, which tells you that pus has collected and needs to be drained. Antibiotics alone cannot penetrate a walled-off abscess cavity, so option A is wrong. Now, why does incision and drainage win? For a simple abscess in a healthy afebrile patient, incision and drainage alone is sufficient. This is a critical board concept. You only add antibiotics when there is surrounding cellulitis, systemic symptoms like fever, or the patient is immunocompromised. Option C, incision and drainage plus antibiotics, is tempting, but the question specifically tells you the patient is afebrile and healthy with no surrounding cellulitis described. Option D, warm compresses and observation, might help a very early abscess, but once fluctuance is present, you drain it. The answer is B, incision and drainage alone. Antibiotic selection is heavily tested on boards, so let me give you a framework. For outpatient skin infections, you need to distinguish purulent from non-purulent. Purulent infections, like abscesses, need methicillin-resistant Staph aureus coverage, so think trimethoprim, sulfamethoxazole, or doxycycline. Non-purulent infections, like simple cellulitis, are usually caused by streptococcus, so you cover with cephalexin or dicloxacillin. For severe infections requiring inpatient treatment, you need intravenous vancomycin for methicillin-resistant Staph aureus coverage. For polymicrobial or necrotizing infections, add piperacillin tazobactam for broad-spectrum coverage. The boards love testing when to escalate from oral to intravenous antibiotics. The triggers for escalation are failure of oral therapy, systemic toxicity, rapid progression, or immunocompromised status. You can find more details on antibiotic algorithms in your first aid infectious disease chapter and in your question bank. Here is your third practice question. A 62-year-old man with long-standing diabetes and peripheral neuropathy presents with a deep ulcer on the plantar surface of his right foot with foul-smelling drainage. When you insert a metal probe into the wound, it contacts bone. The foot is warm with surrounding erythema extending to the midfoot. What is the best next diagnostic step? The probe to bone finding is a major clue here. Think about what diagnosis the board is pushing you toward. Let us walk through this answer. First, spot the classic pattern. You have a diabetic patient with neuropathy, a deep plantar ulcer, foul drainage, and a positive probe to bone test. This combination is classic for osteomyelitis complicating a diabetic foot infection. The probe to bone test has very high predictive value, and the boards love to include this finding. Now, know the key distinction between the answer choices. Surface wound cultures are unreliable because they only capture colonizing organisms, not the true pathogen deep in the wound. Plain radiographs can show bony destruction, but changes often take weeks to appear and are frequently normal in early osteomyelitis. Bone biopsy is the gold standard for definitive diagnosis, but it is invasive and not the best initial step. Magnetic resonance imaging is the best initial imaging study for diagnosing osteomyelitis because it has excellent sensitivity and specificity and can detect early bone marrow changes. The answer is C, magnetic resonance imaging of the foot. Here is an important test-taking pearl. The board loves to test the distinction between erysipelas and cellulitis, and many students get these confused. Erysipelas presents with sharply demarcated, raised, bright red borders. It involves the epidermis and superficial lymphatics, and it is almost always caused by group A streptococcus. It commonly affects the face and lower extremities. Why does this matter on the exam? The board will either present a photo or describe those sharply raised red borders and ask you to identify the condition or choose the right antibiotic. For erysipelas, the treatment is penicillin or amoxicillin because it targets group A strep specifically. If instead they describe diffuse, flat, poorly demarcated erythema, that is cellulitis, and the treatment is cephalexin or dicloxacillin to cover both strep and methicillin-sensitive staph. Memorize this distinction. Review the dermatology images in your board resources so you can recognize these patterns visually. That wraps up our review of skin and soft tissue infection test-taking strategies. Remember, the key frameworks for these questions are simple versus dangerous, superficial versus deep, and purulent versus non-purulent. Review the infectious disease and dermatology chapters in first aid and your question bank for clinical presentations, antibiotic algorithms, and image-based questions. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you with personalized board preparation and residency matching. If you found this video helpful, please like and subscribe so you do not miss our upcoming board review content. Good luck on your exam, and we will see you in the next video.